America's Mental Health Agency funded 900 new grants by this point last year. This year, 109. Tom Insel checked this stat the night before we recorded. He ran that institution for 13 years, and here's what he said.
I just checked on this last night through NIH Reporter. We're recording this in the middle of May 2026, and as of today, NIMH has funded 109 new grants. By this date in 2024, the agency had funded 900 new grants. So this is not where this country should be.
Just finished up a wonderful conversation with Dr. Tom Insel. Dr. Insel is most famous as the former director of the National Institute of Mental Health, which he ran for 13 years. But he's a wonderful polymath, a basic scientist who did important neurobiology research in the 90s. He's become an entrepreneur over the course of the last decade or so, worked at Google and Verily, and then 5 different startups, very much focused on outcomes. Broad-ranging conversation that I really enjoyed about all the lessons along the way, and love that he remains insatiably curious and still pushing to make the world a healthier and happier place.
Oh, thanks, Mark. Delighted to be here and excited to be able to chat with you.
So maybe as some context setting, before we get into specific issues, I'd love it if you walk for our listeners through kind of your career, because you have been a real polymath, and everything has been brain and mind related, but a lot of different circuitous journeys here. And I'm curious about sort of what drove that and common threads as you started your career as an early trainee at UCSF and all the way through to the work that you are doing today.
Yeah, I mean, quickly, it's certainly been nonlinear. I started with training in psychiatry, as you said, at UCSF, and then went on to NIMH intramural, where I did research early on, clinical research on OCD. Those were the days before it was called OCD. It was OC neurosis at that point. So it was kind of disruptive at the time to be giving people pills for that. Got bored and got really interested in neuroscience, which was blowing up at that period in the 1980s and 1990s, and sort of retrained and started all over, and did bench research for 25 years. And in that case, really went after questions about the neural basis of complex social behaviors, everything from affiliation and attachment to parental care, all that. Then ended up being recruited to the NIMH in a kind of it was a leadership position. So that really took up the next 13 years, as you said. And left in 2015 to go to, of all places, to go to Alphabet, which was then just Google. So I came in just as it was happening and stayed for a couple of years, and then decided, gosh, I really want to do my own thing. As you said, everything's been in the mental health space broadly, mental health, neuroscience, behavior. And really, to your question, what drove it was just, I get bored easily, and I get interested in new stuff all the time. And in each case, something was happening in the broader world that sort of pulled me along. So it was kind of the, that golden era of neuroscience in the 80s and 90s. And then I think the NIMH period where neuroscience came back to psychiatry. And then in this last 10 years, it's really been the opportunity with technology. In the last 3 years, it's really been AI, which has kind of gotten me really, really pumped.
And did you face pushback at sort of looking at, I'm going to call it more mechanistic stuff as opposed to softer, like, oh, it's just all part of the mind?
The science that matters is the science that changes the paradigm, that's really disruptive, that lays a whole new path. But the science that often gets rewarded, and the science that we tend to, mostly gravitate to, is like just this putting another cell on the coral reef that somebody else has already begun. And so it is important, I think, for students. We just had a session at Stanford about this earlier this week to talk about, how do you go where no one's gone yet? And how do you do that in a way where you're not going to get a lot of acceptance or a lot of reinforcement for that? And yet, in the long run, it's the person who starts the new coral reef that is probably doing the most fundamental work. It's hard to do.
I couldn't agree more. And we could have a very long sort of meta science conversation. I think that among other things, the reward mechanisms are set up in ways that are really tough. But one of the things, as I've done more episodes on this show, that I've always admired scientists who pushed the boundaries. But I had John Crystal on the show last year, and John is he's now the august esteemed chair of psychiatry at Yale, and very, well-respected creator of many of the most important breakthroughs with neuroplastogens, things like esketamine for treating major depressive disorder. But when he started his work 25 years ago, he was not the chair of psychiatry at Yale. He was an early career scientist working on stuff that people thought was sort of taboo, right? It was what Timothy Leary had made bad news in the 60s. And so I think I think it's a very interesting thing, the sort of the courage of the early career scientist who's willing to do this. And one of the things that's interesting about that is I think it often lends to entrepreneurial behavior later in their career, because there's some shared things in terms of curiosity, willingness to push on things that matter, even if the world is telling you no, et cetera. And so it's probably not a coincidence that many of these scientists who have pushed boundaries also ended up having some sort of entrepreneurial journey, whether they were actually founders or just founding scientists of things that came out of their labs. But I've seen more and more of that as I've explored the field.
Yeah, I think that's a good observation. Some of it has to do with just willingness to take risks and say, okay, I know this isn't the safe path, but it's the thing I'm really passionate about, so I'm gonna do it. In my case, it meant that I lost my job. I got fired for doing this kind of work because it was just considered literally taboo, and it was an honest disagreement. A new scientific director who said, "We just don't think that's what NIMH should be doing. The kind of work you're doing, it's not."
So fascinating. I'm trying to understand this. So the politics from that to being the national director of the NIMH, presumably among other things, a change in the administration. But so how did that happen, and what was the mandate when you came on?
Yeah, Mark, it's really interesting because it was a short period. It was like 8 years, and I left I was forced out, to be really clear, in 1994, and I ended up going to Emory, where I ran the Primate Center and was in the Department of Psychiatry. And with huge gratitude to Charlie Nemiroff, who helped me through that transition, along with leadership at Emory. And the deal was I could continue that research line, and in fact, it just accelerated enormously during those 8 years. So that really was the best thing I could have done for my career in science. But the transition back to NIMH was there was a new administration, although I don't think that mattered. I think it was having a new leader at NIH overall, so not just for NIMH, but there was Steve Hyman came in as the NIMH director, and then there was this guy, Elliot Zerhouni, who joined as the NIH director under the Bush administration. And he really felt, he was a radiologist from Hopkins, and he felt that he was close to Saul Snyder, and he felt deeply that the future of NIMH should be linked to neuroscience and not so much to sort of traditional psychiatry. So he went out hunting for someone who was, technically a psychiatrist, which I was. I'd at least been board certified and trained, but I hadn't had any connection to the discipline for 20 years at that point. I didn't go to the meetings. I didn't read the journals.
You're an interesting combo there, right? So you're a brain scientist who's also a psychiatrist. So maybe there's not like full organ rejection, as it were.
Yeah, I think that was kind of it. I mean, they could sell me as somebody who, belonged to the club, at least at some point, although I'd gotten so far away, I didn't, I really didn't have any connection to the guild of psychiatry. And I was a pretty serious, I went to every neuroscience meeting from 1980 on. I never missed, and had created, at this point, I had a huge NSF grant, a $40 million grant, to really build the field of social neuroscience. And that was a world of mostly, undergraduate faculty and, people who were often field biologists. And it would just drove me crazy. I came back to psychiatry. Everybody talked about animal models. I thought, I don't even know what that is. I study animals, and I deeply involved in the biology and social biology of animals, from insects to fish to vertebrates. But I have no concept of what an animal model, like, why would you even, we don't think of that term. We actually study animals we do comparative neuroscience.
Did you have any overlap with, now that I think about this, any overlap with E.O. Wilson and work with him?
Yeah, I didn't work with him. I knew him. He was super supportive and really friendly. The person who really had an impact on me was Sidney Brenner, who, was probably, I guess he's mostly known for his role in the sort of origins of molecular biology. But what Sidney really was, kind of, and what I always tried to be, was a good comparative biologist. He was just always on the hunt for some weird species in which nature had done an experiment that was really important and interesting for us. So, like, what was the smallest genome, that kind of thing.
The microcosm that represents a larger macrocosm that you can sort of pull out of something interesting and strange. I mean, that's why I mentioned E.O. Wilson, is I feel like the work with ants and bees and was sort of seminal in helping us understand that, I mean, clearly there's a neural basis for this behavior. It shouldn't be that hard then to extrapolate to humans and maybe get people to stop doubting some of the things that you were looking at. But as always, I think there are camps in science. Well, so jumping ahead then, my understanding is you have some famous quotes, and I think some of this came from a book that you wrote, but about how the time at the NIMH, with a lot of focus on neurobiology, actually ultimately didn't bend the curve in sort of patient outcomes in a way that you would have hoped, and that, at least in part, some of the things that you've learned maybe since then are that the social determinants of outcomes are also incredibly important, and this, I guess, in some ways isn't surprising. Like, human psychology and health and happiness it's about your brain, it's about your mind, it's also about the environment around you, it's about how much support you do or do not have. Do you have food insecurity or not? Like, all of these things ultimately are wrapped into sort of the health and happiness of, say, the American public. And I can imagine it's a tough thing if you're running a scientific organization and ultimately your lever is like, I can fund you or not. So I'm curious, if you were to go back, would you spend the money the same way? Would you, and how do you think about sort of the role of the NIMH and as someone who sort of sat in that seat?
Yeah, it's a question I get asked a lot, Mark, because there's some kind of misunderstanding about the role of the NIMH. A lot of people think of the NIMH for what it was in the 1970s and 80s up until 92, when NIMH was part research, part services. So the whole Community Mental Health Act under the Kennedy administration and the development of community mental health centers across the country was done by NIMH, amazingly. That was its original mandate. In 92, the institute split, and everything related to services moved to SAMHSA, and everything that was really fundamental research and even clinical research stayed with NIMH. So that was when NIMH became really part of NIH again, and it was an institute just like all the other 26 other institutes and centers at NIH. So it's a research agency, and the idea is it funds science that will change practice, not tomorrow, but in 10 years, 20 years. So I don't really have any regrets. I think anybody who had come in 2002, 2003 would say, wow, the human genome is a big deal. We ought to probably see if that's going to be relevant to schizophrenia, bipolar illness, and depression. Yeah, so I mean, that became an important area for science. The advent of high field strength imaging and allowing us to look at the activity of the brain, not just the structure. Boy, I thought, like, that's pretty important. We should try to understand whether this thing we call major depressive disorder is like one thing or 10 things. And can we now separate those out and develop biomarkers and new diagnostics and all of that? So I don't have too many regrets about that. I do think it was smart for us to hedge our bets and to invest heavily in clinical trials, which we did for some period of time, the first really large scale trials. And I think the work that we did around developing interventions for serious mental illness, coordinated specialty care, the whole Naples effort to try to understand the earliest phases of psychotic illnesses and whether they were preventable and whether we could move earlier. I think all of that, which tends to get overlooked when people talk about that period, I think that was important as well. But I did feel, and that's part of why I wrote the book, was that, that kind of sense that the house was on fire and we were working on the chemistry of the paint. I think that's the quote that starts the book. And I actually still believe the chemistry of the paint is super important. But as I got into my 60s, which was 10 years ago, I started thinking, like, how much more of that do I want to do? Or is it time to actually, for me personally, focus on putting out the fire? And but I wouldn't want NIMH to give up on the future. I think it would be a real mistake if, that agency said, oh, yeah, we just need to be like SAMHSA and make sure that people are using 988. That's just not, that's really important, but it isn't.
But basic research matters too.
Yeah, exactly.
Yeah. And I it's a biased opinion here because I am married to a physician scientist, but like we need the grant giving organization. We need to fund the stuff that isn't yet translational. Because without that, you don't have anything that's translational. And without that, ultimately, you don't have new therapeutics. And yes, some of this is social determinants and some of these other things, but also some of this is understanding basic brain biology and having some ways to make it work. It just takes a little bit of patience.
So, Mark, let me just interject because I totally agree with you. And I just checked on this last night through NIH Reporter. We're at we're recording this the middle of May, 2026. And as of today, NIMH has funded 109 new grants. By this date in 2024, the agency had funded 900 new grants. So this is not where this country should be. And we, if we really care about coming up with better treatments and better outcomes for people with mental illness, we do have to make some bigger investments in research. I always felt actually that the agency was terribly underfunded, even when we were at 1.5 to over $2 billion a year, that the problems are really complex and tough.
It's always felt to me like one of the crown jewels of America, like underpinning some of the other things that are wonderful about the United States and our entrepreneurial spirit and ability to make great things. It starts with great science, which becomes great technology, which becomes great businesses that change the world and make people's lives better. And we have, in part because of wonderful grants from the NIH and the NIMH and other grant-giving organizations like that, have had the most vibrant ecosystem for forever. Anyways, we'll move off of politics maybe onto something more hopeful. I would love so you made this interesting career shift and obviously into much more entrepreneurial work. You mentioned 5 different startups. I'd love to hear about them and maybe more specifically how you're thinking about AI and other technology advances. It could be, I don't know, optogenetics. There's lots of things. AI sort of has sucked the oxygen out of the room. And of course, it is astonishing. But there are other amazing things happening that are AI adjacent, perhaps like optogenetics and others that are very interesting to people who work on the brain and mind. Anyways, I'm curious sort of what you're working on now and what you're thinking about now.
Yeah, I think there's a lot there. I'll just quickly say that, a dozen 5 startups, they've all there's been a sort of through line to this, which is how do we get better outcomes? And certainly one of them, the early one that got a lot of attention was called MindStrong. And this was 10 years ago. It was one of the first companies to go after digital phenotyping in a serious way, using signals from your phone to sort of figure out, are you getting depressed? Are you getting anxious? All of that. I think the concept was probably right in at least directionally. The execution maybe not so great. I think we learned a lot in that experience. And the thing that I took away from it was it's great to have cool technology and to get better data. But at the end of the day, if you want to get things adopted, you have to understand the healthcare system as a marketplace. And unless you're saving somebody a lot of money, it ain't going to happen. Either you're helping somebody to save, which I learned was actually kind of the same thing as saving money. So I had no understanding of this when I was at the NIH, and even when I was at Verily and starting Mindstrong, that we really have, as innovators, as entrepreneurs, we have to understand the marketplace in a much deeper way. You would do that, by the way, in any other area. But for whatever reason, all of us have become so enthralled with technology and science, we kind of forgot that actually somebody has to pay for stuff if it's going to happen. And so understanding the world of the payer in healthcare, whether that payer is public or private, understanding their pain points and the flow of the money and how it works and how providers get supported and what their worlds are like. So getting the patient, provider, and payer perspective took me a long time to kind of fathom. And
I thank you for the confession. I think it's healthcare, health tech is so hard. I mean, when you were starting this journey, it was not like you were young and naive, right? You'd been an important research scientist. You'd run the largest, grant giving organization in the world for mental and behavioral health. You'd been around the block, and yet it was still difficult. And I do think, I have great admiration for people who work on health techs and biotechs for all these reasons, because the first principle is like, I'm going to help make people healthier. Amazing. And hopefully build a successful business along the way. Also terrific. Oh my God, is it hard? And it's hard because of what you point out, that the multiple stakeholders who are not always aligned. There are no other businesses that I know that feel like this, where like what the payer wants and needs is not necessarily what the provider wants and needs, and it's not necessarily what the patient wants and needs, which is the most important thing. But you really must hit all three, or your business is not going to work.
You said that much better than I have and could. That's exactly the way I see it. In the world of startups, we talk a lot about product market fit. And as I work with a venture capital group called Gray Matter as an advisor. So we look at a lot of companies. And what strikes me over and over again is the products are pretty good, but the market is so dysfunctional. It's really hard. Just as like a microcosm of that. You're a startup and you're working on a kind of month-to-month basis with, probably a pretty short runway in which to actually move the company forward. When you start talking to payers, their idea is, well, maybe we could do a pilot in a year for 9 months. And then depending on that pilot, we could have a conversation about whether you actually would come on board as a partner, where we would put you in lots of different provider clinics a year or two after that. So they're working on a multi-year.
It makes it very
timeline.
difficult, among other things, now that I put my investor hat on here for a second. It makes it very difficult to fund these businesses too, because
Totally.
Even if everything works, the timelines, ultimately, like this, it's an ROI business. It's like, okay, great. 9 years in, the business is finally clicking.
That's right.
So even if it's really clicking, you do an IRR and it's like, it's okay. It's tough.
Yeah. A big piece of what I've been doing in the last two companies is moving from fee for service kind of paradigm to a value-based paradigm, which is, I think everybody agrees, is kind of what you want. But again, if you're doing value-based payments, you're waiting 18 months to see your first nickel, right? Your first return on that investment. And that's really tough if you've got no revenue for 18 months and you're a startup. So companies I'm really excited about now, the last two that I've done, one is called Vana Health, which is in the serious mental illness space. And it's basically an outgrowth of the book that I wrote called Healing. And it's trying to essentially develop a payment model for all the things that today we know are critical for recovery, but they're not paid for. So coaches, clubhouses, psychosocial rehabilitation, all this stuff that we know, like, supported employment, supportive housing, stuff that really does matter if you have schizophrenia and you want to get back to work and you want to recover. We know people will recover if they're given great care. And if that care is sustained and it really focuses on rehabilitation, not just medication and, the acute needs, but nobody pays for it. And so it never gets done. So we have refactored that in a way to convince payers who cover Medicaid that it's actually in their best interest. They will save money if they provide rehabilitative services, which are not expensive, and they bring down their total cost of care. And it turns out we have brought that total cost of care down a lot, by at least 35, 40% in several different cities. So it's That's Vana Health. And it's been, it's really, as you were saying, Mark, it's taken a few years, but after 4 years, it's really taken off. And it's cool to see.
First of all, it must be incredibly gratifying because this is really important work. And for folks struggling with schizophrenia or getting back on their feet, I think it must be transformative. And congratulations on sort of getting through that 2, 3, 4 year period. Because first, you have to make the product. You have to get somebody to pilot it. Then you have to develop the data, probably publish the data. And then and only then does it become possible, really, I think, generally to have conversations with payers about this. And, most of the successes I've seen in the field, that often there's sort of a hack to drive revenue in the short run while they're trying to get through to this sort of larger vision. When I was at Guardant Health, the fact that there were existing CPT codes for genomic testing for tissue that we could use and repurpose for liquid biopsy meant that we could generate tens and even hundreds of millions of dollars in revenue to pay for what we really wanted to do, which was develop the technology to do early detection of cancer. And so it was, in its own, it's funny to call it a hack because it actually helped hundreds of thousands of people. So I don't mean to diminish the importance of molecular characterization of tumors, but it was like, that was the way from here to there. And the unfortunate thing, I think for a lot of these businesses, sounds like for you as well, like the first couple of years, you're just like burning venture money. And it's all about like, can I get somebody to believe my story that I'm going to get there?
And that's why you take the venture money, is to build something and where there may not be any revenue. The last company I did real quickly has actually done exactly what you described, which is we found the hack that would allow us to get some revenue while we built it. And that's a company called Benchmark Health. And that really, in some ways is kind of came out of my frustration with the whole digital mental health industry, which has, by this point, it's gotten, $14 billion in venture investment. Probably 400 companies have been launched really hard and Jiminy may be the exception, but for the most part, it's hard to show any real impact on public health needs. And, if you look at the numbers, it's actually pretty disheartening to realize that even with all this venture investment, all this innovation, all these great products, actually, we haven't moved the needle again at all.
In other forms of care, right?
We took it from cardiology.
Yeah, cardiology,
right. And cancer,
oncology, and I think it started with this observation that people who are themselves healthy enough and educated enough to advocate for themselves or have a spouse or somebody who can do it end up doing better.
Totally, yeah. And it turns out it actually really works. People love it. The Net Promoter Score is north of 70. People have, but the hack for us was using, initially for the first year, the sandbox for building this was using primary care practice referrals. So PCPs sent us patients, and that allowed us to use collaborative care codes to fund the company for the first year. That's not our business. That's not, we're not a collaborative care company. But while we build out the model, it paid the bills and allowed us to just about hit profitability in the first year, even though, that's just not what we're about. But at least it's been one way of trying to build the plane and fly it at the same time. But that's actually, I'm pretty excited about that because that is the first company which I think takes care of the payer, the provider, and the patient in a really serious way. Patients love it. Providers, on the demand side, the PCPs are so happy with it, they're sending their own family members, which is a great sign. On the supply side, we have a lot of digital mental health companies that are so excited. Their CAC has gone from $250 a month per patient down to $25. So that's a really good deal for them because we're the referring agent. And the payers are looking at this and saying, hey, this is really cool because it turns out that we kind of knew this, but now you've proven it out that some substantial number of people who PCPs are referring into therapy actually can get by without therapy if they just get some help on SDOH needs, if they get a little bit of support, they do just fine. So about 15 to 20% of our patients never receive clinical services and yet do really well. We're not a provider. We're it's all about showing the outcomes and demonstrating that actually we're probably paying too much in many cases, too little in others, but There's a way, again, to kind of reorganize this around just a real focus on quality, building, trust with patients and families, and providing quality outcomes. And that by itself, I think, promises to change the mental health care system in a fundamental way. We're just at this point, we're basically in Massachusetts only. We're 1 year in. We're sort of proving it all out. But the early indications are pretty exciting that we've built something that that seems to serve all three of the Ps: the patients, the providers, and the payers.
First of all, congratulations. I love this notion of focusing on outcomes. And my suspicion is that part of the reason that this really works is that the advocate if they're good at their job, can sit across all of the different components of what makes for strong mental health, which includes, like, maybe it's therapy, maybe it's the rest of the social structures around you. How are you sleeping? How are you eating? Turns out inflammation is really important for a lot of people who are struggling with anxiety and depression. And actually, turns out inflammation is really important in a lot of serious mental illness too. Maybe it's your meds, maybe it's you have the right meds, but the med management and the intrinsically multivariate nature of what drives somebody's mental behavioral health, I think makes it very difficult for an individual provider to take care of all of that. And the incentives are like to a hammer, everything looks like a nail. If you are making a pill, you want to sell more of the pill. And so having somebody who's in the middle of that advocating, which feels like it's also helping to manage, right, it does not surprise me, I guess, that the outcomes on that would actually be really strong.
Yeah. And there's one more thing to add, and this sort of ties back to your original question about AI. In 2026, we have so many good tools that people can use to get information, to get support. If the issue is loneliness, to at least give them a sense that, in the case of ASH, Slingshot's product, we're going to help you to be less lonely. We're going to give you the skills to make social connections offline. Just so that our advocates are armed with, AI journaling apps and a pretty good understanding of what are the AI products that are out there that can be helpful for any of the given issues that people come in with. So it's an amazing time to be doing this because we're finding that more and more people can get the outcomes they want without clinical care. And I think for payers, that is a complete revelation. And for patients, to give them something that empowers them to get what they want on their own, with their own agency, that's pretty cool. People really like that.
Yeah, absolutely. Well, speaking of time, we're going to bump up against time here soon. So maybe the last sort of future-facing question for you. I mean, obviously, what's happening with AI is astonishing and wonderful. I'm curious, if you look out 2, 3, 5 years from now, what do you think the world looks like for mental behavioral health vis-a-vis AI? What will be the most important sort of changes that have happened as a result?
Yeah, I've been quoted saying that AI for mental health will be what DNA was for cancer, that it will, in many ways, transform the field, but not in the way that most people jump to, which is the chatbots. I do think that's going to be interesting, and I think having purpose-built chatbots like Therabot and Slingshot, and there are like 5 of them now that are really interesting. Still early days on that. A little hard to see adoption when it's up against ChatGPT and others, but I think we're learning a lot there. So there's something there. But the more important thing to me is the effect this has in other areas of care. So the one I often jump to is to think about what diagnostics will look like going forward. That will, and this really has to do not so much with generative AI, but with just old school machine learning circa 2016, the ability to, but for every encounter, to be able to collect deep data that involves voice and speech and maybe face emotion and just a range of other kinds of data that will tell you something about how somebody thinks, how they feel, how they behave. Being able to track sleep, being able to track behavior broadly through wearables. I mean, I think that will, for a field that has not had objective data to help with diagnostics or even to help with outcomes, it will transform the field. It'll give us measurement-based care for sure. And that should happen yesterday, right? And it will give us,
Well, and so the DNA to cancer analogy actually is spot on. I mean, understanding the genomic nature of cancer allowed us to develop better therapeutics. It started with the diagnostics. If your non-small cell lung cancer is EGFR driven, we treat it very differently than if it's not. And today, the era of personalized psychiatry and psychology is promised, but not really yet here. And I agree with you that AI will have a lot to do with actually making that happen.
So, Mark, just to put a pin in this, because, in a sense, we have thought that personalized psychiatry would come from high field strength fMRI, or maybe some, genomic finding. I'm putting my bets now on using AI to just define emotion, cognition, behavior in a much more objective, holistic, ecological sense, not just because this is what somebody looks like when they're sitting in front of me in my office, but this is the picture we have of them over the last week, everything from sleep to activity to homestay to all the stuff that gives us an understanding of somebody's world. That, I think, is that's where the DNA for cancer analogy really plays out.
What's so interesting is because, I have a broad role, not only at Jiminy, but also sitting here at South Park Commons, where we see, we have companies that are able to look at sort of the digital detritus of your life, not just, and they're not looking at your camera. You don't have a therapeutic relationship with them. There's just the digital detritus, and they can tell you so much. It's actually sort of terrifying how much they can tell you about what's happening with you. And if you were to take the positive view of that, so not just the digital detritus, but like I have my ring and my watch and my camera that is facing me, and you can hear, everybody's running granola all day long. You get to hear my voice. If you were to tie that into good, sophisticated models that are there to help you understand how you're doing, and ultimately maybe include intervention, like put down the phone at 9:00, stop doom scrolling, go to bed. There's some obvious stuff. Anyways, I agree with you. I think we will push into a world of very interesting new diagnostics, and it doesn't require the biomarkers don't need to be sophisticated for the diagnosis to be sophisticated, I guess, is one way I think about that.
They don't even need to be bio. They could be cognitive or behavioral. And that's, we don't have the language for this yet, but I think this is the next thing that will happen. This, in being able to use scribes to capture the interview and to personalize it.
What's so interesting about that is a lot of resistance to AI. No, people do not resist scribes. Every single care provider on earth is like, this is the best thing that's happened to me since, I went to medical school or did my studies. Yeah. I think that's been one of the things that's wonderful, because it takes a burden off of the provider, but also there's so much signal in there. So interesting. Well, I know we're now actually over time, so I want to respect you and let you go, Tom. But this was such a wonderful conversation. Thank you so much. Such an interesting career and so many interesting projects. Look forward to future conversations and seeing what else you build.
Absolutely, Mark. Thanks for having me.
The thing I keep coming back to from this conversation is Tom's framing that we've been measuring the wrong thing for 20 years. We've been measuring access instead of outcomes. That feels like a thread running through everything that's broken and everything that could be fixed. In the next episode, I'm talking to Andy Slavitt, who ran CMS under Obama and served as Biden's senior COVID advisor, about what it actually takes to reform the system from inside. If Tom told us what's wrong, Andy spent his career trying to fix it. In 2 weeks. In the meantime, if you run a care organization, what does success actually look like for you? Drop it below and follow NeuroCompass so you don't miss what's coming. If anything from this conversation is sitting with you, a question, something you've been noodling on, something you want to comment on, something you would push back on, drop it below. And follow NeuroCompass. We do this every 2 weeks, and the next one is worth the time on the calendar. NeuroCompass is brought to you by Jiminy Health. To find out more about Jiminy Health and how our clinical-grade AI solutions are helping to shape the future of behavioral health, visit JIMINIhealth.com. And then make sure to search for NeuroCompass in Apple Podcasts, Spotify, or anywhere else your podcasts are found. Make sure to click subscribe so you don't miss any future episodes. And on behalf of the team here at Jiminy, thanks for listening.